Hi, everyone. We're going to give everybody a few minutes to join, and then we'll go ahead and get started. Welcome to the AMDA webinar. All right. In the interest of time, we're going to go ahead and get started. I want to welcome everybody to today's webinar. The topic is managing treatment of newborn screen patients with Pompe disease. So today we have with us Dr. Priya Kishnani, who I think everybody knows quite well with Duke University, and we're very excited to have her. We also have Erin Huggins, who is also from Duke University, and I think probably everybody knows her quite well as also. And they're going to be speaking to us on when a patient is screened and comes back positive with a newborn screen of Pompe, what are the best management techniques? What have they learned so far now that newborn screening is becoming more common in the US? And with that, I'm going to turn it over to Dr. Kishnani. Thank you so much for being here today. And I'm excited to hear your thoughts.
Thank you so much, Tiffany. It's always a pleasure and a privilege to participate in these sessions. And without taking up too much time, I'm going to try and share my screen. And the title of my talk, or our talk, is New Insights into Pompe disease since the advent of newborn screening. These are my disclosures. And I think, again, to set the stage, all of us here know that Pompe disease is a continuum. And I want to tell you that the definition of classic infantile has changed through the years, from being the first few weeks to first few months to saying the first few days. And I think it's really present at birth. These babies present with hypertrophic cardiomyopathy, and there's death within the first year of life. And then everything outside of infantile Pompe disease is what we know as late onset Pompe disease. And the distinguishing feature, as I think of it, is the lack of the cardiac involvement in the first year of life. So as we learned through the years, this natural history of untreated infantile Pompe disease, I think, is a reminder of what the clinical course was prior to enzyme therapy, and also what our understanding was before newborn screening, where we said that the first signs and symptoms were at about 2 to 2.7 months of age. Diagnosis was at about 6 months of age, because at that time we did it via skin fibroblasts. Ventilator use was by 7 months of age, and death by about a year of age. And pre-ERT, this is what we knew about the natural history of late onset Pompe disease. And this was from the Dutch cohort and beautiful work from Dr. Van der Ploeg's group, where you could see that we thought of it as first complaints and diagnosis at about 28 years. About a decade later, there was this progressive muscle weakness. And around that time, there was also the use of ambulatory devices, and then also the use of ventilator support. So about 2 decades from when the diagnosis was made, individuals with late onset Pompe disease, required some kind of ventilator support, or a majority of them needed it, and also that there was progressive muscle weakness. So this is what we knew about the clinical course. And then if we fast forward and see that in 2006 and 2010 respectively, L-glucosidase alpha was approved as a treatment for Pompe disease. And at that point, with a lot of major steps taken in the field, what was recognized, if you see to what is called Group A, this is from the Pompe registry, you can see that for babies with infantile Pompe disease, there was delay of about 1.4 months from symptom onset to diagnosis. And then if you look at B and C, these are individuals with late onset Pompe disease. Group B is those who are 12 years and younger. And what you see is that the diagnostic delay here is about 12.6 years. And for adults with late onset Pompe disease, the median delay is about 6 years. So again, when you look at this group here, it's teaching us something already, that we're taking a very long time for those who have late onset Pompe disease, especially those with pediatric presentation. So we also learned through time that there were many factors, such as the age at when enzyme therapy was initiated. We also learned that antibodies played a very important role. We learned about the dose of enzyme therapy. And I'm just going to show you a quick snapshot, a video of early versus later treatment. And this is a few weeks delay in treatment initiation for infantile Pompe disease results in a very different motor outcome. Both these children are alive, but there's a significant difference in their motor response to enzyme therapy. So then just quickly touching upon cross-reactive immunological material status. And again, as a reminder, everyone with late onset Pompe disease is what we call Crim positive. That is, they've got some residual enzyme activity. But this plays a very big role and has a critical role as we think about newborn screening as well. So this is Crim positive on what we call a Western blot, and it can be very strong band, as you see to the extreme left, or it can be a very weak band. And then you've got what we know as Crim negative. Why do I bring that up? Once again, because now we are recognizing that irrespective of Crim status, about a third of babies with infantile Pompe develop high antibody titers to the enzyme therapy and behave no differently than Crim negative. And when I talk about Crim negative, the idea is that despite enzyme therapy, they develop antibody titers, have a poor clinical response, and then succumb despite the enzyme therapy. And my point again to make is that there are some Crim positive who behave the same way. So now the next learning is that through the journey, we developed what we know is an immune modulation protocol to help the Crim negative babies. This is a course which is done at the time of enzyme therapy with the ideas that you fool the immune system to treat the enzyme, that is the administered enzyme, as a self enzyme or as a self antigen. The body doesn't mount an immune response, and then the baby does well. So this led actually through a lot of data to an update to the prescribing information by the FDA and EMA, and this label change, where now Crim assessment has become a part of the management tool of infantile Pompe disease. And then if someone is Crim negative, then using immune tolerance induction. So why I bring this up is because as we head in the space of newborn screening, this is actually lessons which we learned from Taiwan. So Taiwan started newborn screening many, many years before the US. And for the infantile cases there, what was learned, and this was the short-term results, is that patients who were treated with enzyme therapy early, if they were picked up by newborn screening, had a much better outcome in terms of invasive ventilator-free survival and overall survival. So if you see here, those who were detected through newborn screening, the number was 5, and those who were clinically detected in Taiwan, you can see that survival was 100% by 24 months of age for those picked up by newborn screening versus 89%. But when we raise the bar to invasive ventilator-free survival, you see that 100% are alive and invasive ventilator-free if identified and treated early through newborn screening, as compared to 2/3 if they were, when you look at the ones that were clinically identified. In a longer-term follow-up from the same group in Taiwan, they now had tracked 10 babies for anywhere from 28 months to 90 months, and all of them were invasive ventilator-free. All were walking independently, all were attending school, but there was still some residual myopathy and some other symptoms that were persistent. Now, here's where I want to bring your attention. All these babies in Taiwan are Crim positive, so the immune response issue is not as much. But the takeaway was that early diagnosis and treatment leads to better outcomes. So then another group in Taiwan actually looked at their cohort of babies, and what they showed is that days matter. If you started at a median of 11.9 days versus 21 days, the outcome was significantly different in terms of the age of independent walking, as well as the overall CK was much lower in the group that was initiated early. I must say, when I first saw this data, I wasn't that certain about, how this could pan out. However, I'm going to come to this as we talk further. Now, talking about late onset Pompe disease, in the Taiwan cohort, they had 13 of these newborns that were tracked with later onset Pompe disease, and all of them had a 4-year period of follow-up. They were followed every 3 to 6 months. They had a physical exam. They had a CK or CPK measurements done. And interestingly, 4 out of these 13 ended up on enzyme replacement therapy. And you can see that this was anywhere from as young as 1.5 months of age to 3 years of age. So already a beginning of understanding that if you diagnose early and you monitor early, you may result in treatment. So now when they started looking under the microscope, they looked at 6 patients who with asymptomatic later onset Pompe disease and looked at their pre-treatment biopsies. And this is where I'm trying to lead our thinking off, is that the symptoms that we're looking for may be subtle. We may not be looking sufficiently because we're not doing a good amount of kinematic or postural evaluations of these babies. And if we just look at standard measures of functionality, we may be missing a few key points. So my point here is that here, when they looked at these babies, their indication for treatment was hypotonia, frequent falls, persistent elevations of CPK, hypotonia, lordosis, etc. But here is where I want to also show you a little bit. This is a pre-treatment muscle biopsy from a baby with late onset Pompe disease picked up in Taiwan by newborn screening. And what you can see is that there's already the accumulation of glycogen. And then if you look at the electron microscopy, you can already see, this is another newborn screen, late onset, that there is already this autophagic buildup that is occurring. Again, a caveat here is that they don't carry the leaky IVS splice site mutation, which is the most common pathogenic variant that we see in the US. And so the lessons from Taiwan, whilst important, were not sufficient to get Pompe on the RUSP. So we did preliminary work as a community, and ultimately Pompe was added to the recommended uniform screening panel in 2015. And today, I think 45 states, including our state of North Carolina, is screening for Pompe disease. So this is a large percentage now of babies in the US that are being identified if they have Pompe via newborn screening. Now, one of the things to see is that this number may actually move closer towards 90% of them are late onset Pompe disease, and the vast majority of them carry this IVS splice site variant. So what we know so far, right, is from Taiwan newborn screening, we know that all Crim positive, if you treat IOPD early or infantile, they do well. From our data, we know that if we immune modulate Crim negative, they do well. We also know that if you treat higher than the standard dose or the approved dose, those children do well. So applying all these principles now to Crim negative babies in the US, let's see what we've learned. So I will go through this very quickly because I just want you to take this message, is that we divided up these babies who were Crim negative into those who were treated before 4 weeks of age, those who were treated between 4 weeks and 15 weeks of age, and then those who were treated who were older than 15 weeks of age. And all of them received immune tolerance induction. All of them were immune tolerant, but you'll start seeing a difference. In terms of invasive ventilator-free survival, the babies that were initiated in the first 4 weeks were alive and invasive ventilator-free. Those who were treated in, between the 5 weeks and the later onset treatment group did well, but some of them ended up requiring invasive or non-invasive ventilation. Of course, overall survival was the same. The next message I want to give you is even the heart, we talk of it as the star player. If you start early, you have less disease burden and you can normalize much quicker. So in those who were treated within the first 4 weeks of life, now these are Crim-negative babies, they had a normalization of the left ventricular mass index pretty quickly, and the baselines was much higher in the ones who were treated when they were older than 15 weeks of age. And by 21 weeks of age on ERT, the babies who were started at within 4 weeks did really well, and they had a normalization as compared to the other two groups. Now, if you look at biomarkers, again, what you can see is that HEX4 or GLUC4, which is a biomarker of glycogen accumulation or of glycogen breakdown, you can see a very, very significant difference. The early treated group actually started normalizing their HEX4 as compared to those who initiated beyond the first 4 weeks of life. The same trends with CPK, normalization in those who were treated early or in the first 4 weeks of life compared to the other two groups. And so let's add this up. What does it do in terms of feeding and motor milestones? You see that those babies who were treated early or in the first 4 weeks of life were feeding by mouth, they were walking, they were doing extremely well as compared to those who were treated beyond the first 4 weeks of life. As I said earlier to you, there was no real difference in the antibody titers, but the other caveat was that as we have learned through the years, when you treat with a higher dose, you do better. And so those patients who were started at under 4 weeks of age, as knowledge has increased, also ended up being a group of babies that received, a higher cumulative dose of enzyme therapy as compared to the other group. So this is now looking at Crim-negative babies with infantile Pompe disease in the US. And the take-home message is that if you start, before too much damage has occurred, you can do extremely well. And that there was no difference in the immune response. So immune tolerance induction works. But then when you layer it with a higher dose of enzyme therapy, early treatment, and immune modulation, even Crim-negative babies who are the most at risk can actually do well. So that was the first message for infantile Pompe. And then I'll just touch upon late onset, and Erin will talk more about this. So what are we doing for those babies identified with late onset Pompe disease in the newborn screening setting? So as this group knows, a number of us had met and had developed, monitoring guidelines, which were published in Pediatrics. And this is how it went. What we said is that if the baby was identified with late onset Pompe disease, monitor them. If they're asymptomatic, then you do not start enzyme therapy. If you're symptomatic, then you start enzyme therapy. However, what do we mean by asymptomatic? I think that's the elephant in the room here. And the question is that the approach to monitoring motor status may also differ based on the region or on the underlying pathogenic variants. For instance, those in Taiwan don't have the IVS splice-site variant. They tend to present a bit earlier, at least that's what the literature tells us. So once again, we don't know about late onset Pompe disease with the IVS splice-site mutation. And in the US, the line of thinking was that these patients typically present later on in life, exactly like the data that I showed you from the Dutch cohort. There are a few publications which have shown earlier presentation. However, this is not very well understood or well characterized in the literature. So now with newborn screening, we are recognizing a different course. And I'm going to talk about just the initial experience with newborn screening for late onset Pompe disease at our institution. So this was 7 babies who came to Duke. They all carried the leaky IVS splice-site variant. They had come to Duke for a second opinion. 3 were compound heterozygous, that is, they had one IVS splice-site and another variant. 4 of them were homozygous, so carried the IVS splice site on both alleles. And then what we learned from them was that some of them had early features, which Erin will talk about through a follow-up larger study. That's not these 7 babies. And what we learned from this was that physical therapy was a very integral part in the management and follow-up of babies with late onset Pompe disease. So I'm going to show this to you through a case example. So this was a Caucasian female. She carried the IVS splice site mutation and another pathogenic variant. She was presumed asymptomatic by 2 prior genetics evaluations. ERT was not initiated, and the family was told, that she will be symptomatic much later, nothing to worry about. As would be expected, her echo and EKG were normal. However, her CPK levels were elevated since 8 days, since day 8 of life. So when she came to Duke, this was the information that we had. At 5 months, the physical therapist actually at the home institution had already said that there was some gross motor developmental delay with inability to hold her head up, and that the Alberta Infant Motor Scale, which is a functional scale, was showing that she was functioning at the 10th percentile. And so they started weekly physical therapy. When she came to Duke at age 6 months, what we observed was this continued delay in gross motor milestones. We also saw that when we were tracking her biomarkers, you can see that her CK was increased over the entire period of time, right from day 8 of life up to age 6 months. Her other biomarkers of muscle involvement were also increased, and actually her urine GLUC4 was normal in the hands. So that's another lesson to be learned. But here what we saw, and I'm going to show you this little girl, this is published, and you can see that at age 6 months, she was actually able to hold her head up. She was able to actually, put some weight on her forearms. And so this looked really good. But this is where, when you have an experienced neuromuscular PT, and here with full credit and respect for the work done by Laura Case at our institution, when you compare it to a typically developing child, I think this photograph starts to show you that there's a huge difference. And then when you start breaking it down in terms of posture, you see that the baby with Pompe disease actually has excessive hip flexion, abduction, and external rotation as compared to a typically developing child who's able to now raise their weight with arms extended versus on the forearms. So I hope you can appreciate that these are differences which would have easily been missed otherwise. Then now I'm going to show you, this is a typically developing child. And here is a baby with late onset Pompe disease, the same one. Once again, you can see the differences in the supine position. However, all of this could have been missed if we did not really have a good physical therapist evaluating the baby. So at this point, enzyme therapy was recommended and was started. And this little girl is now, I think, 5.5 or 6 years old. We've seen her recently. She is thriving. Her biomarkers are normal. Her motor function is completely normal. I mean, you cannot separate her from any other child that we know. So now when we look at pathophysiology, this is from those babies with infantile Pompe and the lessons that we learned. So this was from the pivotal clinical trial. What we knew already was that when you have some amount of glycogen that's built up, after treatment, you can clear the vast majority of it. But if your starting place has a lot, as you see in the one below, then your clearance is also not so good. So this was the other lesson that, of course, we learned. But then this is something that Erin is going to also highlight, is this is a baby with late onset Pompe disease with an IVS splice site variant. And to the left-hand side is normal control. And this is on H&E staining. And below is LAMP2 staining. So to the left, you can see what appears to be normal. And on the right-hand side, you can already see this is a baby who was already initiated on enzyme therapy. This is 2 months into enzyme therapy, where you can still see the extent of muscle involvement that has occurred. And so with our learnings, what we are seeing is that the epidemiology or understanding of epidemiology has also changed. Prior to newborn screening, we thought Pompe disease overall, the incidence was about 1 in 40,000. But since newborn screening in Taiwan, and since the availability now in the US and in other parts of the world, the epidemiology has really changed. And it's twice what we thought it was, at least, close to about 1 in 18,000. And it varies by different states. It varies in different parts of the world. But the take-home message is that the frequency of Pompe disease is much higher than what we previously thought. And so the lessons that I think we've learned from late onset Pompe disease in newborn screening is that the frequency is higher. The age at symptom and sign onset is earlier than previously thought, and that we do have some monitoring guidance, but this needs to change, and the definition of asymptomatic and symptomatic needs to be broken down further. And so this is a reminder to myself, because this is what I had tried to show when trying to get Pompe on the RUSP, is this is how we had said, is that as a disease progresses, if you pick up and you start treating early, in our minds at that time, under 6 months of age, this is the disease burden that you can, get to. However, you've still got a lot of disease that you've not been able to deal with or to clear because treatment was not initiated early. If you move this further along, this is problematic. But if you start here, this is really what the goal is. And I hope through the years, as we continue to talk about these children identified by newborn screening, that we now have a new natural history, a new clinical course that we should talk about. And in terms of acknowledgements, this is really a partnership. A lot of thanks to the AMDA and to others. Our team at Duke, special acknowledgements to Erin, who I have the pleasure to introduce. She's a fantastic genetic counselor. Her focus has been on Pompe disease and really on uncovering even the challenges with what we call the variants of uncertain significance, which she'll be speaking about, but also, to a global community of physicians without whom we could be here today. So with that, I'm going to stop my screen share and Erin can take the podium.
Thanks so much, Dr. Kishnani. Always a hard act to follow, and I'm excited to share some information that we have gathered here at Duke on a much larger cohort of children with late onset Pompe disease picked up on the screen. And so are you guys able to see my slides okay? Or if you do like a thumbs up or something? Great. Okay, fantastic. So as
Erin, just get closer to the mic if you can.
Oh, okay. Is this any better? Okay, fantastic. So as Dr. Kishnani mentioned, I am a genetic counselor by training. I've had the pleasure of working with her for almost 4 years now. And pretty much that entire time, a large chunk of my time has been dedicated to newborn screen follow-up. And we very recently had newborn screen added in our own state of North Carolina, so very exciting. So I'm going to follow up Dr. Kishnani's talk with a little bit more information on our cohort of patients and then kind of our next steps in what we think is the next best approach to better clarifying diagnosis for these patients. So as Dr. Kishnani mentioned, there is a common genetic variant or mutation known as the IBS splice site variant. It's often referred to as a leaky variant because even though it does reduce the amount of GAA enzyme in the body, it doesn't completely eliminate it. There's still some residual functional enzyme, and so it's referred to as leaky. And because of that, it is pretty much always going to cause late onset Pompe disease. It's present in most Caucasians or those of European descent. Between 60 and 90% of individuals with LOPD in the US and Europe have at least one copy of this variant. Some people are homozygous. What we find, let me just get my pointer. I'm not sure if I can, sorry. There we go. Are homozygous for this variant, meaning they have 2 of the same gene mutation, one from each parent. And with how common this variant is in the general population as carriers, there should be more people coming to clinical attention with this variant combination, but we don't see as many. So that leads us to believe there's lots of people walking around potentially undiagnosed. However, with newborn screening, we're now picking up lots and lots of babies that have 2 copies of this variant. You can also be compound heterozygous, which means you have 1 copy of the IBS variant and another variant. So this could be a mutation like the 525del, which is very commonly seen in infantile. It can be another late onset mutation. But no matter what, if this variant is present, the phenotype we're seeing is late onset Pompe disease. So without that cardiac, the cardiac involvement, the enlarged heart. And so we're learning a lot about what different individuals look like with different variant combinations. And we have found, as a generalization, pretty high variability. This was the publication that Dr. Kishnani just referenced, 7 patients that had come to Duke, all with at least 1 copy of this variant, all demonstrating gross motor involvement by 6 months old. And our team also did a pretty extensive chart review for 84 of our clinic patients with LOPD who had been diagnosed clinically, so picked up later in life, not on newborn screen. And 4 out of those patients had reliable documentation of symptom onset within the first 2 years of life. It's likely that many of them did have this early onset. It just might not have been well documented. So for the sake of this publication, everything that was reported had been reliably documented. And all of them had just 1 copy of the IBS and another variant on the other chromosome. So this tells us there is evidence of early involvement in those clinically diagnosed and via newborn screening. And as Dr. Kishnani showed that algorithm in the guidelines for follow-up of patients, it leaves us with a pretty big question still. What is our definition of a symptomatic patient, and how do we identify one? What tests do we do? What procedures? You know, is there a certain biomarker, a certain physical therapy measure? What is going to tell us when a child is symptomatic? And so about 1.5 years ago, our team published the early clinical phenotype of late onset Pompe in newborn screening patients. And this is a cohort of 20 children. And this particular publication was just on the baseline data. So what did they look like on their very first trip to Duke? And so this is made up of 12 male and 8 female patients. We saw them for a baseline visit, and they were anywhere between 6 months and 21 months of age at the baseline. We saw them again 6 months later, and then again 1 year later. So at the end of the study period, after the 1 year follow-up, these kids on average were about 2 months old, or excuse me, 2 years old. As you can see, most of the participants had 1 copy of the IBS variant. 4 children were homozygous, meaning they had 2 copies, and 2 children did not have this variant, but did not have a cardiomyopathy and thus were classified as LOPD. So we did a systematic clinical evaluation. A lot of these evaluations were based off of the recommendations from the newborn screen working group. And for the sake of time today, we're going to focus on the outcomes of the physical therapy evaluation, which consisted of both kinematic and postural assessment, as well as standardized testing. So things like 6-minute walk tests, which might be familiar to some of you as adults, but for children, there are equivalent measures. And biomarker testing, looking at CK and HEX4 or GLUC4. We also did a speech and swallow evaluation in echo and EKG in all of these children as well. And all of the baseline data from all of these are published in that paper. So this graph is showing a little bit of the most common musculoskeletal findings, so those postural or kinematic changes that Dr. Kishnani had mentioned earlier. And the blue bar is representing those that were persistent throughout the study period. And the orange bar represents those that were improved over the study period. So you can see the most common findings, the most common was defined as present in 50% of the children or more, so at least 10 children. Was hip extensor weakness, increased posterior pelvic tilt, so again, those hips, hip involvement, scapular winging, which is a prominence of the shoulder blades in the back, and I'll show you guys a picture of that, and abdominal oblique weakness. And these did worsen over time in these patients. Up to 90% of patients had hip extensor weakness at some point in the study visit. The ones that were most improved were still the same muscle groups, but in different positions. So when these were very young babies and they weren't able to sit or stand or walk yet, we were looking at these movements in supine or laying down or in supported sitting. And so what we're seeing is weakness across various stages of development. So in the earlier days of the study, when we had very young children that were not as developmentally advanced, we were seeing weakness in the supine or laying down posture, and continued to see those findings as they were sitting up. So that lets us know that we are looking in the right place, and we do know that hip weakness is common looking at clinically identified patients with LOPD. And this, like I said, this publication has an entire list of all of the findings that we saw. A few pictures of what I mean by all of these things. So it's scapular winging, this prominence of the shoulder blades here you can see. And this is a finding that's fairly common in young children in general. A head lag, so when you pull baby up from a laying down position, does their head come up with them, or does it lag a little bit behind? Tightness of the IT bands here in the thighs, and this posture, which I would say is very common among this population, this rounded back and this kind of thrusting forward, or this pelvic tilt in the hips. Just a quick case review of patient 1 in our cohort that had persistent musculoskeletal findings, tight IT bands, abdominal obliques, and hip extensor weakness. So all those common findings that we saw. So here is this child at 7 months old, and you can appreciate this is in the prone position. You can appreciate this wide turning out of the hips, hip abduction. So instead of being closer into the body, they're splayed outwards. Here's the same child a few months later in sitting. You see this kind of lean forward, an abdominal oblique weakness. The legs are splayed pretty far out, and that tilt is there as well. And at the same age, but in standing, we see what's called a lumbar lordosis, or this curvature of the back. And so Dr. Kishnani showed this slide as well. This is from this patient, again, after starting enzyme replacement therapy, and showing the increased glycogen in the cells like we see in those clinically diagnosed LOPD. So looking at biomarkers, I think I'm just going to focus on CK for today. 8 children had completely normal CK at the start of the study, and all of those remained completely normal throughout. We had 3 patients that did start enzyme replacement therapy, which are marked by the squares here, and all of them did start out elevated and decreased with enzyme replacement therapy. We also had 1 patient who had the highest CK and did not undergo treatment during the study period, and actually increased CK as the study went on. So 3 of the 20 patients at the end of this period had started enzyme replacement therapy. So all of them had elevated CK prior to the visit. So the reference range, the upper limit is 320, and all of these are almost double that. But post-treatment, the mean CK had gone down quite a bit into the normal range. The AIMS is the Alberta Infant Motor Scale. Dr. Kishnani mentioned this. It is a functional measure done by the physical therapists. Most kids, we want to score that 25, 50 percentile or greater. And actually, interestingly, 2 patients scored within what would be considered a fairly normal range, not too concerning, versus NBS 1 that scored below the 5th percentile. And I have here a list of all of those musculoskeletal findings in each patient. So we are seeing children that do present severe enough to require enzyme replacement therapy within the first couple years of life. You can see here again, the CK in these 3 treated patients did decrease as treatment went on, as the study period went on, and after ERT was started. All patients that had normal CK stayed normal, and of those treated patients, 2 of them had elevated hex scores or gluc scores at some point. And so, interestingly, patient 1, the one that had that very low AIM score and very high biomarkers, has always had normal hex score, and the red mark is indicating the start of ERT. Patient 14 had generally normal hex scores even after ERT, a spike here and here. So this is 2 separate time points, not exactly sure what caused this spike, but a normalization soon afterwards. And patient 20 that had a slight spike above the hex score upper limit with a subsequent decrease after starting ERT. So some critical findings, again, we see pretty high clinical variability, which is what we expected, but all patients had some kinematic or postural deficits. There was no one in the study, even those that were homozygous, that had absolutely no muscular findings at all. And so we recommend evaluating each child as a whole and not based on one individual finding. So looking at biomarkers, looking at the musculoskeletal assessment, the PT scores, so on. The kinematic and postural deficits, or these musculoskeletal findings, may persist over time, but can change and impact as the child develops. So the findings that you see in the first few months of life might still be the same muscles that are affected, but they're going to present themselves in different ways as the child gets older, moving into sitting, standing, walking. So continued physical therapy evaluations as the child grows up is very important. Biomarkers, especially elevated serum CK and AST, could be signs of early muscle damage. GLUC4 or HEX4 is generally normal in this population, but we have seen some children that do have a high HEX score. And so we recommend monitoring those over time and using age-adjusted or age-matched controls whenever possible. So sending to a laboratory that does use specific age ranges. We continue to not observe cardiomyopathy or enlarged heart in children with this variant, and frequency of echocardiograms can be reduced. However, we do recommend continuing electrocardiogram or EKG assessments every year. And the bottom line is, overall, we do see an emerging phenotype in this patient population that does require close monitoring based on the guidelines. And we do hope those get updated in the near future with these findings. And so for the sake of time, I'm going to skip through a lot of this. I think you guys are all pretty familiar with Pompe disease and how it affects the body. So it impedes the breakdown of glycogen in the muscles. It's caused by mutations in the GAA gene, which is responsible for making the GAA enzyme, which is what's needed to break down the glycogen. So if your body's not making enough working GAA enzyme, the glycogen is going to build up in the cells. And this is a visualization of that. So if we're missing the enzyme, that glycogen does not get broken down, but instead builds up to a point where it damages the cell. So as we probably all know, Pompe is an autosomal recessive disorder, meaning that someone with Pompe has inherited two genetic mutations, one from father, one from mother. And so if you guys throw back to your high school biology classes and think about your Punnett squares, so if your mom's genotype is a big G, which is a normal working copy, and a little g, which is a copy of the gene with a mutation, and the father is the same, then there's a 25 or 1 in 4% chance of having both normal working copies passed down and not a carrier, not affected. There's a 50% chance of having one parent pass down the normal copy and one parent pass down the mutation, and a 25% chance that each parent passes down the mutation, thus resulting in Pompe disease. And Pompe does affect all gender and sex equally. This is just another visualization of that. We can skip through it. So whenever we're doing newborn screening, it's not genetic testing that's done first. That's a pretty common misconception I hear. We're not testing the baby's genes at birth, we're testing their blood for the GAA enzyme levels. And this is collected within the first 1 or 2 days of life. And then if that's positive, then we're doing additional genetic testing, because a positive newborn screen is not the same thing as an actual diagnosis of Pompe. So we'll repeat that GAA enzyme level and then do genetic testing to identify the variants or mutations. And I use those words interchangeably here in the GAA gene. It's also important that a clinical workup is done. As Dr. Kishnani mentioned, in infantile Pompe, we now know that we can see symptoms as early as the first couple of days of life. So really important to get anyone with a positive newborn screen for Pompe and very soon for evaluation. And so, as most of you probably know, Pompe was added to the recommended uniform screening panel in the USA in 2015. And we know, as Dr. Kishnani went over, all of the evidence for improved clinical outcomes for those with infantile Pompe and early treatment, but most pickups in the US end up having LOPD. And so how do we best treat those patients and how do we best diagnose them? Because there are challenges in diagnosis. We're not able to tell if a baby has infantile versus late onset based on enzyme testing alone. And so analyzing the combination of those two gene mutations can help figure out if the baby has LOPD or IOPD. As I said, IOPD can be diagnosed based on symptoms. So if we see enlarged heart, high CK, high HEX4, that gives us some of the information we need to confirm IOPD. But in LOPD, we don't usually see symptoms in the newborn period. And so if the genetic variants aren't super clear in telling us what we're dealing with, it can be difficult to confidently say, yes, this baby has late onset Pompe disease. So there's three kind of major classifications of genetic variants. You have pathogenic or likely pathogenic, which is a disease causing, essentially when you hear the word mutation, what you think of, it's reducing that GAA enzyme in the body. Benign or likely benign, meaning it's just a normal variation. This wouldn't even be reported. If you had two benign variants, you wouldn't even have a positive newborn screen because they're not causing low GAA. And then this third category called variants of uncertain significance, or VUS, which means we don't have enough evidence to determine either way, is it pathogenic or is it benign? And that usually requires some further evaluation. With newborn screening, we're getting more and more of these because we're testing more and more people, and a lot of these variants we've never seen before. And so if you've never seen a variant, you don't know if it's present in Pompe or not, it's really hard to determine whether or not it's disease causing or just a normal variation. And you guys might also be familiar with the concept of pseudodeficiency variants, which don't lower the enzyme enough in the body to actually cause Pompe disease. But we get a lot of those on newborn screen as well. So looking at those gene mutations is pretty important. So obviously this leads to some pretty significant questions. If there's no observable phenotype, but not a very clear genetic diagnosis, what do we do for this child? Do these parents have a chance to have another child with Pompe disease? Do we test this child's older siblings? What do we do until we have an answer? And so just to put it all in context, in the GAA gene, there is about 800 of those variants of unknown significance, and then an additional 200 or so conflicting interpretations, so different people calling them different things. Very challenging to interpret. So very high need for work to be done in this area, and that's something a lot of colleagues at Duke are working on now. So very exciting stuff going on there. And of course, big shout out to the clinical research team and the lab team and our participants and their families for being part of the study. We've learned so much from them, and we're so grateful that they travel out to Duke to see us. So with that, I will go ahead and end and turn it over for questions.
Thank you so much, Erin and Dr. Kishnani. I think this was an absolutely fantastic presentation. I know there was one question in the Q&A box that Dr. Kishnani, you already answered about what is an elevated pro-BUN. So if anybody has a question about that, that's in the Q&A box. And if you do have questions, please feel free to use the Q&A box at the bottom of your screen or the chat box, which somebody else did asking about citations. So yeah, we're now open for questions. So feel free to jump in through the Q&A. And I do have some that were sent to me earlier. What is the importance of HEX4? Because from the presentation, it does appear that, at least in this population, it doesn't always correlate with high CK levels. And so really, I guess, what should parents and patients and physicians be looking for?
I could try and take that first. So HEX4 is a breakdown product of glycogen. And the idea is that it needs to escape the lysosome, right, that glycogen, and then it gets broken down by neutral maltase and amylase. And then that's broken down, at different branch points. And the most soluble, or the easiest one to measure, is HEX4. So it has alpha-1,4 linkages and then one alpha-6 linkage. And it's 4 glucose molecules that are linked together. The reason why this becomes an important aspect is for us to remember that if the glycogen is inside the lysosome, then we're not going to be able to see the HEX4 as elevated. So for infantile Pompe, what we've seen in the newborn screen setting And when you compare it to late onset Pompe, it's higher, but some of even the infantile cases are just above the upper limits of normal. And for late onset, it's in the normal range. That's one message. The second one is that we have to use age-related norms because we correct it for muscle mass, etc., and we also correct it, for based on the age of the baby. So if you use just general numbers, you may miss what could be an elevated hex4. But in general, in late onset Pompe disease, the hex4 tends to be normal, which is kind of reassuring, telling us that it's still intralysosomal or there is no glycogen. But when you start seeing other biomarkers that are increased, but more important, when you look at the child, you can see that there is something going on, but it's not sufficient damage where you've got that shearing effect and extra lysosomal glycogen buildup. So I still think it's useful in that context.
So it's basically saying that your CK level and your clinical findings are showing Pompe is in effect, it is present. You're seeing the symptoms, but the hex4 is saying you're not at the level where muscles are necessarily destroyed.
Correct. And I think that's the other take-home message, Tiffany. As you know, in the literature, there are cases, even clinically diagnosed late onset Pompe patients, where the CK is normal. And that's something that we're also learning in the newborn screening setting, is that they may have some of those kinematic or postural findings that Erin pointed out in the face of a normal CK and a normal hex4. And so we've got to evaluate these children in totality and not just, a number.
I think it's important to, oh, I'm so sorry. I was gonna say, I think it's important to know that just because it is normal a lot of the time doesn't mean it's not an important test to have, because if it's been normal at every visit and all of a sudden it starts to go up a little bit, that can be a clue to look at everything else too. CK climbing, are the musculoskeletal findings changing? Is the PT scores worsening? So versus like it was high one time and it was low again at the next visit. So it's a good thing to monitor over time. So when it does, if it does start going up, then that's something that can keep people in. So I think it's still it still should be part of an evaluation. Sure.
And then Erin answered a question in the Q&A, but I think it could be helpful to talk about it a little bit further. You're a parent of an LOPD kid diagnosed through newborn screening, but not currently being seen at Duke. What's the best way to see about other studies happening at Duke to potentially get involved? And Erin said, of course, to reach out to Duke. Absolutely, I think that's great. But, I think in general, to me, the question that we get a lot is, okay, my child is LOPD, diagnosed through newborn screening. What do we need to look for? Erin, in your presentation, you said that all 20 of the children had some clinical findings. So I think that that's very, very enlightening, right? So at what point do these clinical findings mean you should start ERT, because not all of them had? And how do you make that determination, right? If you're not at a center like Duke, what should parents do?
That's a really, really good question. And I'm sorry, I live very close to the hospital, so lots of sirens going on outside right now. So I apologize if that's very loud. So we get a lot of people that reach out wanting to, interested in coming to Duke, or if they can't come to Duke, where do I go? What do I do? A lot of those musculoskeletal findings are very subtle and probably wouldn't be picked up by parents, and might not even be picked up by a general pediatrician because they're so specific to this neuromuscular condition. And so if you're not able to make it to a genetics clinic or a geneticist with expertise in Pompe disease, and I don't know, Dr. Kishnani might have comments on this too, I always say to try and find a muscular dystrophy clinic or an MDA clinic. Even though Pompe disease is different than muscular dystrophy, a lot of those types of clinics will have people experienced in muscle disorders, and that's just going to be an additional set of eyes looking at your child that has more knowledge. And again, it might not be specifically Pompe, but muscular disorders of muscle weakness. So those would be the two things I would recommend, is seeking out a local genetic center or an MDA clinic if you're not accessible to a local.
And how critical is it? How fast? Because I know sometimes patients can have, or parents can have difficulty getting referrals, or it may be further out. What should they do? Because we know time is critical. How, how do we help them?
So one of the things that we have been trying to do is we're trying not to be letting any families think that coming to Duke is essential. We love seeing patients. We learn a lot from each one of them, but there's ways of collaboration. And in the rare disease space, I mean, the collaborations are really global. And that's one important message. No family should feel, that they're tied to any of us. We all try and help. And the goal really is to update or to come up with more refined guidance now that we are learning, from children with late onset in the US. I'm not saying that they're completely different than Taiwan, but the monitoring there is, based on 2 or 3 institutions and all the children go there. It's very different here in the US, right? And so I think that is one of the biggest goals we have, is to try and break this down further so that even a pediatrician could be able to do it in a clinic.
So ideally, by working together, we have guidelines that parents can take with them to their pediatrician or their physical therapist, so that
Yes.
they know better what to look for and then can collaborate. And I completely endorse what you're saying about the collaboration within our community. It's absolutely superb, I think. So another question that people had was, besides PT and lab work, what else should we be doing, looking out for?
I think another important message is a single time point is not really telling you everything, not just in terms of labs, but it also could be in terms of a PT assessment or an evaluation with a physician, right? So I think watching the children over time is kind of an important message to give, because there are certain aspects which can improve, right? It's just variation of normal. We're just watching these children closely. It doesn't mean that if someone has scapular winging or a lumbar lordosis that they are going to end up on therapy. This could be managed through a physical therapy management approach, and we continue to watch the children. So that's another important message. And that I think one thing we are seeing is that the frequency of echocardiograms, is not needed as much. Like, we don't want to over medicalize these children. We want them to, have healthy lives, and to be typically developing kids. So, reducing that frequency of that, because we know, at least for the ones with the IVS splice site variant, is important. But I think a very good friend to have is a neuromuscular PT.
Mm-hmm.
I want to add on that too, because I get to that question and then to the last part of what you said, Dr. Kishnani, because I feel like when I'm talking to families, I get a lot of questions and a lot of anxiety about what should I look for, what's it going to be like, and especially for late onset, which I can speak to, this is a slowly progressive condition. So there's not a day where you'll wake up and your child suddenly won't be able to walk, or suddenly will have lost all motor skills or have trouble breathing. That's not something we see with LOPD. And so I to Dr. Kishnani's point of your child living a pretty normal life, that's exactly what we want. We're doing this work so that you as parents don't have to sit at home and sit anxiously awaiting some kind of sign or symptom. And even if there is one, like even if there is a high CK one time, or even if there are some findings on PT evaluation, like Dr. Kishnani said, it's not just one time point. It's let's look at this over time, and can we do other things in the meantime, like physical therapy, speech therapy, whatever is needed. So the last thing I want is parents to sit at home anxiously waiting for some sign to show up. And even if it does, it's not going to be a very sudden emergency. And if so, it's probably not related to Pompe disease.
I think that's really important, because there's that line, right? You want to be vigilant and aware, but you don't want to assume that every trip and fall is Pompe disease.
Yeah.
Because babies trip and fall.
There's a good bit of normal kid stuff that goes on too. And even outside, even kids without Pompe disease, a lot of those kids need PT and speech and might need a little extra help in other places too. So it's really important to realize your kid isn't necessarily different than other kids. There's just specific needs for specific children that, again, may or may not even be learning a lot about what that looks like.
This isn't necessarily directly related to the topic, but I think an important question. And it's more for you, Erin. If you have a parent come in with a child diagnosed in newborn screening and there are older siblings, I'm sure parents ask, what should we do? What would your recommendation be?
So we have a confirmed newborn screen, meaning we've got two, disease causing mutations, we've got low GAA, we've got enough evidence, because at the end I talked about how sometimes it can be a little unclear. We've got a confirmed, yes, this is Pompe disease diagnosis for each child that has both the same mom and dad, so full siblings. Any other older siblings are going to have a 25% chance of having the same thing, Pompe disease. And so I always recommend testing as soon as possible. And getting them in for an assessment as well. So we see that a lot with newborn screening, older siblings getting diagnosed. And I think there's a good kind of point to that, because a lot of these parents had no idea. It's just suddenly newborn screening started in their state, or they moved to a different state and they would have had no idea in their older child. So there's something to be said about most kids. And as we know, even before newborn screening, a lot of people living their young lives, adult lives even too, without obvious symptoms until they got much older. So I would say testing siblings, but it's, again, especially for LOPD, because that's really what we're talking about here, because IOPD would be identified clinically. That would be the first step, is getting that enzyme testing done to see.
There was one more question in the Q&A. With ERT, can cardiomyopathy be recoverable in 2-year-old IOPD patients? If yes, how many infusions would be required, do you think? Which I think might be a bit of a difficult question to answer. Would you prefer that family to reach out to you directly?
Yeah, I actually did try and reply on the chat box as well to that question. But in general, I think the cardiac response is very good. I think that's another take-home message. And the fact that the baby is 2 years old tells us this is not classic infantile, this is non-classic infantile, which also should give more hope, which also means the child is likely Crim positive, which is another good positive hope. So please don't worry too much and feel free to reach out.
Thank you. And then just, I know we're over time, but for a closing thought, how would y'all recommend that we, as a community, best help and support parents with babies identified by newborn screening? How can we best work together?
It's a good one. And I think for those with infantile, I'm definitely going to leave parents with the thought that there is an urgency there. There, I would say, need to move quickly. I think the guidance is there, and so avoid any delays, right? And if it means that you've got to really be proactive, it's the right thing to do. For those with late onset Pompe disease, it's not a medical emergency, as Erin put it. And in terms of collective learning, I think a lot of families are speaking to each other, and I think y'all are each other's best guides, if you ask me. But if there are things which do come up, we've always said this, right? We learn from every patient. And so if there are things that come up which seem atypical, unusual, or something that's a question mark, please do raise that awareness, through you, Tiffany, or through us, or through others, because that one question sometimes becomes another parent asks the same question, and then a third, and then you pay attention and you figure out that this is a way or something that was not paid attention to. And in terms of this together, I really would suggest that, yes, there is a goal towards monitoring guidance so that it's more readily available, to the scientific community and the physicians as well as the patients.
I'll add on to that. You ask, what can we do as families? I think a lot of parents feel like they've had all control taken away from them. They come home from the hospital with their baby that appears perfectly healthy, and all of a sudden get a phone call, which leads to Googling, which leads to anxiety, which leads to us getting a phone call, and what do we do? What do we do? And so there's a lack of control in that situation. We're trying to figure out, is it infantile, is it late onset, is it Pompe at all? Okay, we got a diagnosis, now what do we do? And in the setting of late onset Pompe, especially, I think when there's not super clear guidance on when to start ERT, if to start it, what to do. So I agree with Dr. Kishnani in sharing with each other and with us and with your local doctors. I always say, no, it's cliche, but no question is a dumb question. And so if you're not sure if is this Pompe or not, send a message to your doctor. And also there's lots and lots and lots of information out there, support groups, Facebook groups, Google pages, but just realizing that not everything you read on the internet is accurate anymore and might not apply to your child specifically. So I think it's really important to remember that all these kids are going to look a little bit different. We've shown that in our own study. And so realizing that your child might be very different than someone else's child, even if they both have LOPD or they both have IOPD, might still look very different. So recognizing your child as an individual and treating them as such, I think is really important. And the second piece of gaining that control, and you're the one now in charge of your child's appointments and making sure they get to everything they need, but also to advocating for other children and other families in your community. So sometimes that is teaching other people about Pompe disease, or teaching your kids' classmates about Pompe disease. I've had a few families that have gone at the state level, the government level, to improve the newborn screening process. There's lots and lots of ways to get involved. And so, yeah, I really want to empower families to do what's best for them.
Yeah, I completely agree with everything y'all have both said. And then just as a, additional reminder, if you have trouble, reach out to the AMDA as well. We work very closely with Dr. Kishnani and Duke and, others. And I think what I've always noticed is the US, to Dr. Kishnani's point, is so different than a country like Taiwan, where there are 2 centers. We are so spread out. You have different people seeing different physicians, and maybe a physician that's never heard of Pompe. So if you need help advocating, we can help with that. We can help you get your doctor in connection with. We're here for anything, especially in the IOPD context, where it may be very urgent and you may be having trouble getting your local physicians to act quickly enough. Reach out. That's what we're here for. We are here to support you in your journey, wherever you are in your journey. So, yeah, I really can't thank you enough, Dr. Kishnani or Erin, for this wonderful discussion. I'm sorry we ran a little bit long, but I think it's been incredibly enlightening and helpful. And like you said, Pompe is a spectrum. Every patient is different. And so that one should always be at the forefront of our minds. Don't expect your child to be exactly like somebody else. Your child is your child.
Thank you so much for having us.
Thank you so much.
You.
And that will close today's webinar, and it will be available on the AMDA website within the next week or so. So thank you so much, everyone.
Thank you.
Bye-bye.